Bismillahirrahmanirrahim. Today in this lecture we will first study the classification of tumors of the larynx, and then we will study the neoplastic, benign and non-neoplastic tumors of the larynx in details. First, the classification. Tumors of the larynx can be classified into two main categories. One is neoplastic tumors, the second is non-neoplastic tumors. The neoplastic tumors may be benign tumors or they may be malignant tumors. On the other hand, the non-neoplastic tumors may be solid or they may be cystic ones. The benign laryngeal tumors, they are less common as compared to the malignant laryngeal tumors. The important benign laryngeal tumors are squamous papilloma, which is further classified into juvenile type and adult onset type squamous papilloma. The other benign laryngeal tumors are chondroma, hemangioma, pleomorphic adenoma, rhabdomyoma, neurolemoma, lipoma, and fibroma. The malignant tumors of the larynx are number one, squamous cell carcinoma with various grades of differentiation. It accounts around about 95 to 98% of the malignancy of the larynx. The other malignant tumors of the larynx are verrucous carcinoma, cord cell carcinoma, adenocarcinoma, adenoid cystic carcinoma, chondrosarcoma, fibrosarcoma, and lymphoma. All these, they constitute 2 to 5% of malignant tumors of the larynx only. So 95 to 98% of the malignancy belongs to just the squamous cell carcinoma. Now, the non-neoplastic tumors of the larynx, as I have already said, that they may be solid tumors or they may be cystic ones. The solid tumors are vocal nodules, vocal polyp, Larynx edema, contact ulcer or granuloma, intubation granuloma, leukoplakia, and amyloid tumors. The cystic tumors are ductal cysts, sacculosis, and laryngocele. Now we will discuss some of the important benign tumors, and then we will discuss some of the important non-neoplastic tumors of the larynx in details. First, the juvenile papillomatosis, also known as respiratory papillomatosis. This is the commonest benign tumors in children. This is having the propensity of a recurrent disease. Etiology of juvenile papillomatosis is a DNA virus called human papillomavirus type 6 and type 11. Parts affected by this disease is, as I have said, is the larynx, especially the supraglottic and glottic regions in majority, while subglottic, trachea, and bronchi less often. Because the respiratory tract is involved, that's why it is also known as respiratory papillomatosis. It is important to note that children having tracheostomy due to respiratory distress because of laryngeal papillomatosis have higher incidence of tracheal and stromal involvement due to seedling. Now you can see here, this is a normal larynx. These are the two vocal cords. This is the anterior commissure, and this one is the posterior commissure. And some of the upper proximal rings of the trachea can be identified in this figure. On the other hand, the other figure shows the two vocal cords, and there is a small swelling on this two vocal cord. This is the papilloma. This is a papilloma of the larynx. Now this is another photograph which is showing multiple juvenile laryngeal papillomatosis arising from the two vocal cords as well as the supraglottic part of the larynx. Clinical features. The patient is often a child, usually having age 3 to 5 years. The child will have hoarseness. He may have aphonia sometimes, respiratory distress, and he may present with stridor in some cases. Diagnosis can be made by the history, age of the patient, and then performing fiber optic laryngoscopy, and then it is confirmed by direct laryngoscopy and biopsy of the lesion. Treatment. Treatment is number one, surgical treatment in the form of microlaryngoscopy and carbon dioxide laser excision. This is the most ideal treatment for this disease. But the recurrence is common, so procedure may have to be repeated for several times. Second is microlaryngoscopy and excision of the papillomas with cup forceps or with a micro debrider. Second mode of treatment is the adjuvant medical treatment. For about 20% of the people, surgery is not sufficient to control their laryngeal papillomatosis. And so, additional non-surgical and or medical treatments are necessary. Some varieties of non-surgical treatments include number one, interferon, second, antiviral drugs, for example, Cidovir, Ribavir, and Acyclovir. And third mode of adjuvant medical treatment is the photodynamic therapy. Fourth one is the bevacizumab. This is a monoclonal antibody against vascular endothelial growth factor. It has shown promising result as an adjuvant therapy in the management of recurrent respiratory papillomatosis. The fifth one is the human papillomavirus vaccines. Although vaccines are normally used to prevent infections from happening, HPV vaccines can be used therapeutically. For most patients, the HPV vaccine significantly increases the length of time needed between the surgeries. Now, non-neoplastic tumors of the larynx. Non-neoplastic tumors are not actually the true tumors. They are tumor-like masses resulting from infection, trauma, or degeneration. More common as compared to true benign neoplasms. They are of two types. One is solid, for example, vocal nodules, and the second one is the cystic ones, for example, laryngosphere. First, the vocal nodules. Vocal nodules are also named as singer's nodes. Vocal nodules or singer nodes, they are formed symmetrically at the free edge of the vocal cords at the junction of anterior one-third with the posterior two-third. This is the site of maximum vibration of the cord and so site of maximum trauma. Size of the vocal nodule is variable. It may range from pinhead to half of a pea. The victims are those people who speak for long periods or at high intensities. For example, teachers, actors, singers, qawwals, lecturers, and school-going children who are assertive and talkative. Now you can see here, these are the two vocal cords, and there is a small swellings on the free edge of the vocal cords. These are the vocal nodules at an early stage. This is another photograph showing the two vocal cords having two vocal nodules at the free edge of the vocal cords. These vocal cords, they are at late stages because their size is a bigger one as compared to the previous photograph. Pathology. Due to vocal abuse, there is trauma to the vocal cords. This trauma will lead to edema and hemorrhage in the submucosal space of the vocal cords, which will result in fibrosis. The overlying epithelium undergoing hyperplasia in the form of nodules. So in this way, due to vocal abuse, there is vocal nodule formation on the free edge of the two vocal cords. Gross appearance. The vocal nodules, they are soft, reddish and edematous at an early stage, but they become grayish or white at later stages. Clinical features. The patient will present with hoarseness and vocal fatigue on prolonged phonation. Treatment. If the patient presents at an early stage, the patient is advised to have a voice rest and speech therapy. And if the patient comes late, then excision of the vocal nodules under microscope with carbon dioxide laser surgery or excision with cutting instruments under the microscope. The second important disease in this is the laryngocele. Laryngocele is an air-filled cystic swelling due to dilatation of the saccule of the larynx. It is of three types. Number one is the internal laryngocele, which presents within the larynx. The second one is the external laryngocele, which presents in the neck when distended saccule herniates to the thyroid membrane. And the third variety is that of combined or mixed laryngocele, when both internal and external components are present. You can see here, this is the epiglottis, this is the true vocal cords, and this is the ventricular bands of the larynx. And this is the swelling. This is the swelling from the saccule, which is because it is within the larynx, that's why it is called internal laryngocele. Now this is external laryngocele in the right side of the neck of the patient. Pathology. The laryngocele results due to raised transglottic air pressure. Usually the victims are trumpet players, glass blowers, and weight lifters. Clinical features: hoarseness, the patient may have cough, and respiratory obstruction when quite large in size. An external laryngoscele presents as a soft, reducible neck mass enlarging with cough or Valsalva's maneuver. Compression of the mass may produce a gurgling sound known as Bryce's sign. Investigations. One, Number one is the X-ray soft tissue neck with Valsalva's maneuver in AP and lateral views. The second is CT scan of the neck with Valsalva maneuver. All these investigations will be able to show you the swellings containing air. Now this is the CT scan. You can see here this is an external laryngoscele. This is CT scan showing internal laryngoscele. It has not come out in the neck. CT scan showing internal laryngoscele. Now you can see here that this is CT scan showing both components. This is the internal component and this is the external component. So we can call it as mixed or combined laryngoscele. Treatment. If the patient comes with external type of laryngoscele, then surgical excision through external neck incision. And if the patient presents with internal type of laryngoscele, then marsupialization through endoscope. In adult, risk of carcinoma in the laryngoscele is there. The incidence is, however, variable. It may range from 4.9% to 28.8%. Thank you.